Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Gursaran Sidhu. Ma'am is MBBS, MD, FIACM, FICP, FACCP USA, physician gold medalist, HOD of internal medicine at Sidhu Hospital, Ludhiana. Now, with the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is neglected tropical infection in everyday practice. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Thank you, Skyon. Thank you, IJCP, for giving me this wonderful opportunity to talk on a topic which was really neglected, but it is so very important as a very important part of our clinical medicine and of our daily practices. So, why do we say neglected tropical diseases? Because they're very common in tropical countries, and because even at the global and national level, it lacks a public health attention, and the many affected people they are living in the poverty with inadequate access to clean water, basic sanitation, and healthcare. So, why are these tropical diseases neglected? It because there's been a limited funding and research, and it affects the marginalized population, and it is not prioritized in the global health policies historically. And what are tropical infections? This is a group of tropical infections that affect uh, all kinds of patients, not only deprived communities in the tropical countries, because these organisms they live in the tropical countries, they live in a tropical environment, and people who are in the deprived communities, deprived means who have lack of access to clean water, sanitation. Those are the people who have these problems. And another big thing is they remain underdiagnosed and untreated. And it's a huge burden. Over 1 billion people they affected worldwide, and 149 countries report at least one NTIs, we call it, neglected tropical infections. And believe me, it's a very major cause of disability. So, what are the causative organisms in the tropical areas? So, we can divide them mostly in as helminths, protozoas, bacteria, viruses, fungus, and ectoparasites. Some of them, with the improving health conditions, with improving economics in India, have almost not seen, like guinea worm is not seen now. India has eradicated. India has also eradicated onchocerciasis. So, though we do see schistosomiasis and lymphatic filariasis in the helminths, so in the protozoa, similarly, we do see leishmaniasis, but trypanosomiasis is a disease of the African countries. We don't see it here. And bacteria, we are into the program of eradicating leprosy. We see trachoma, but we don't see, we've almost eradicated, we've never seen, and in India, yaws and brulee ulcers are not eradicated. But dengue, rabies, many fungus, they are in fact still a huge problem in India. And out of the helminth parasites, like they are transmitted from the basically from the soil for walking barefooted, and they have the poor water supply. So this causes like ascariasis, ringworm, trichuris, strongyloides, schistosomiosis, tinnias, threadworms, or cysticercosis, which we mostly actually as physicians we see mostly as neurocysticercosis, but we have echinocosis, COP. And this is the one I said India has eradicated dracunculosis, foodborne dermatidosis, onchocerciasis. This is not a problem in India. The protozoa which are seen in India, which are our problem, are like Cantamiba histolytica, though we see it very less. I had done a clinical trial on Cantamiba histolytica, and I had to get stool examination to see cyst of the Cantamiba histolytica. I just could manage only 5 patients. I tried a lot, lots of stool samples, but I could just manage 5 patients to conduct this trial. So basically, the number is gone far less. Similarly, giardiasis, but Falciparum vivax and uh, Plasmodium vivax falciparum are still our great concern. Leishmaniasis, Kala Azar, babiosis, balantidiasis. These are our main problems in protozoal diseases. But like Chagas disease and human African trypanosomiasis, they are not seen in India. They are not our problem. Out of the bacterial diseases, cholera is still a huge burden, I tell you, because normally we don't see it, but we have a area near Ludhiana where there is a lot of migrant population of Bihari laborers, and many times the water pipes or with and the sewerage pipes, they get mixed up somewhere or the other, and many times out of that area we had been having lots and lots of numbers of cholera. And somebody who has seen it is cholera, you really don't need any test to find out that this is cholera. This is so much of watery stools that it is not the stools we count. We actually had been putting rectal pipes and then calculating by liters how much the stool, watery stool is there, and correcting dehydration by calculating how much, like we calculate in the urine output, we've been calculating the rectal output from those tubes, and then correcting it. So we don't have to forget it. It is not a disease which is not seen. We still see it. Shigella, Salmonella, E. coli are of course very very common. Leptospirosis we don't forget. Similarly, Bartonellosis, atypical bacteria, including Mycobacterium bovis, and leprosy. We near I practice outskirts of Ludhiana. This is a place Doraha, and we have a government-sponsored leper center just at the outskirts of Doraha. There are patients, still patients who have, or patients of leprosy patients who are not anymore infected. I do some many times take camps to see those leper patients, and they come from, lot of them have they have come from Odisha. I think it's a government program, so they have patients from Odisha. We do give them, sometimes, because that's our favorite as an NGO. When we have to work, we do conduct our camps there. We give them many times rations and everything whenever they have the religious samagam at their place. So, not that leprosy is not seen in India, leprosy is still. So, for skin consultants, if you happen to see a lesion which is hypopigmented and there is no sensation, please do consider leprosy. It can still be seen, especially when you have to find out, you have to see from which endemic area the person is coming, and a family history of that person is very, very important. Relapsing fever and trachoma is still seen. And viruses, they're so very important. Dengue, chikungunya, Zika, Japanese encephalitis. Yellow fever is not seen in India, but anybody who's traveling abroad has to get a vaccination, especially to African countries. We need a vaccination for yellow fever. Similarly, in enteroviruses 71 and related viruses, HTLV1, HTLV2, and other non-HIV retroviruses infection. Rabies is our huge concern because we want to prevent rabies. I really don't know, doctors these days see rabies patients or not. No, the number has gone down because of the public awareness. It is not because that the dogs are not a problem. The dogs are a huge problems, giving the legal protection to the dogs which are neither vaccinated. They are the dogs, the stray dogs in India are neither vaccinated nor they are uh, you know they still keep on producing more and more dogs. No care has been taken, and they bite each and every person around. So rabies is a huge problem. But thank God that public is aware, and immediately they come for the rabies vaccination. And the good part is that we have a huge window where it gives a times for the rabies vaccination to act. It must be very rare that rabies vaccination doesn't it must be a very it can happen that the rabies vaccination is still not effective, and the patient has got rabies, in which case we might have to give antibodies. But otherwise, mostly we at the first, as soon as the person have a dog bite, cat bite, bat bite, or a monkey bite, we do give them rabies vaccination. uh, Lately, yesterday only, we had a patient. This is called in Punjabi a go. Go is a huge lizard, and it's called like a. Uh, it's not a lizard, but it's a huge animal. It is called go. It is present in Punjab, and this can also give rabies to the person, and many viral hemorrhagic fevers. And fungi are also common in patients who are immunocompromised: mycetoma, coccidioidomycosis, chromoblastomycosis, and deep tissue mycosis. And believe me, I also still continue to see scabies infection, and those itchy lesions and small dots, and the family getting involved. There's no problem to diagnose scabies, and there's no problem to eradicate scabies or treat scabies. The like I said, the dracunculosis, the guinea worm disease. This is a neglected tropical disease, but thank God it has been eradicated from India since 2000, and since 2006, India has announced eradication of yaws as well. Lymphatic filariasis, also transmitted by the mosquitoes, which is causing abnormal enlargement of the limbs of the feet and the genitals from the adult worms, which are inhabiting and reproducing in the lymphatic system. And lymphatic filariasis causing lymphedema. Repeated infections lead to elephantiasis. This is a social stigma. Maybe we don't see these days such cases. As a medical student, I had seen, and subsequently also as a practice, I had seen patients who were coming from Bihar. And because it keeps on persisting, one patient you will be keep on seeing again and again, though it is very less common. These days we don't see it very often. So now the soil transmitted helminthases are the Ascariasis, the hookworm, the Strongyloides, the Trichuris tricharis. This is a group of huge intestinal helminth infections who are transmitted through soils which is contaminated by the human feces. The incidence of these infections is becoming, with the improving sanitation, with improving, every household having its own washrooms, own toilets. Even in the villages now, there is no kacha houses. People don't go out to ease themselves. So the chances of the soil getting contaminated with the human feces is far less, but the water which is given to the fields from the sewerage pipes is still there. So this the not that the infection is not possible, infection is still very possible. Around 10 years back, I had a case. This was a child who was brought by an army personnel to me. He said, "I am coming after a year to see my child, and I see my child. He's a 5 year old, and he just even doesn't look like 5 year old. He looks like a 3 year old. He's not growing properly." I said, I saw the child. He looked anemic. We just added. I thought I must deworm the child. I gave him deworming, and I gave him little of iron. And 7 days later, So it's very stingy, you know. The man brought a jar. What is it? Oh, it was filled with the worms inside. He said the child has passed so many worms. He's continuously for 3 days, he's been passing so much worms in the stool that he's filled up the whole jar with them. It's very jittery, very difficult to see. It wasn't a pleasant thing to see, but I was so happy that those little tablets has made what a huge difference to this child. And that man was it, not that man anyway, I myself was so much, it was a sight. Could there be so many worms, so many ascariasis or hookworm in this child, in this small 5-year-old child, that this could, they were like, more than 750 grams of contributing to his weight. So, still continue to deworm your patients as often as you can. There is no harm, just 3 tablets of albendazole. I think, many times as a rule, also, I do. I'm very quick at giving albendazole to my patients, just as it's as good as giving them vaccination, because we as such today adult vaccination is so important to us. Then why not, just treat it like a vaccination if this can be prevented. Just a patient has come to you for any abdominal pain, he may not be having this. What is the harm giving 3 tablets of albendazole? It may make a huge difference, at least to 20 patients out of 100. Because I again remember one of my patients who was admitted to us, a lady, 56-year-old, came with severe pain abdomen. He was admitted and final diagnosis of acute pancreatitis was made because her amylase lipase were very high and ALT and alkaline phosphatase were also high. Her ultrasound was absolutely normal. Her CBD had no stones. There was no gallbladder stones, and she's of course a non-alcoholic. I was really wondering what could be the cause of acute pancreatitis in this lady. We were treating her symptomatically, and she was NPO with the Ryle's tube on her and only on IV fluids because she was suffering from acute abdomen. Third day, I saw a huge ascaris coming out of her Ryle's tube. This was an eye opener for me. This this ascaris, this large roundworm, had blocked her common bile duct, giving her a acute pancreatitis. So, at odd situations, also remember cause of acute pancreatitis could be an helminthic infection. Don't neglect them because we just don't think of the small little things. Therefore, we will think of we need to do ERCP, we need to do a sphincterotomy, we need to ease this thing. We think of lots and lots of things. But, dear friends, clinical medicine and examination and important differential diagnosis. Don't think these are small things. These are what is important is the diagnosis, is the real diagnosis. And this is what will make you a good clinician. And this will what you will be always be proud of yourself. These are small things which make a huge difference. That's why looking at that scenario, I am very quick to giving albendazole of deworming most of my patients. And once we dewormed that lady, oh, she was feeling so good. Immediately, this was, uh, of course, we were symptomatically treating her, but then she improved so much. And this is a huge cause of anemia and malnutrition in children. And basically, all the children, because now we may not be, getting it from the bad water. We may be taking a normal water. Water may be very sanitized. We may be all be taking from filters, but we do have fast foods. We do have contamination even in all kinds of dhabas and fast foods and any hotels. They could really give you a lot of infection. We and the route is fecal route. Cysticercosis is again, it refers to, it's an infection caused to the exposure to eggs of Taenia solium, or what we call as a poke tapeworm, and it spreads via the oral route through contaminated food and water. After the ingestion, the egg pass through the lumen of the intestine into the tissue and migrate preferentially to the brain and muscles. And what we see actually in muscles, we've always tried to find out in a patient of neurocysticercosis, does he have cysticerci on the muscles or not? I haven't seen them very commonly. We, as a PG student, we had been looking for them, but didn't find it. Neurofibromatosis we saw as very, very common, but not the cysticercus uh, in the muscles. But to us now, what is most important is the neurocysticercosis. Is the patient so common, adults as well as children? They come to us with seizures. We do their CT scans. We picked up multiple lesions, and we these lesions are contrast enhancing lesions. Many times we find multiple small calcified lesions. And going back, while in our PG days, even we've been going through series which PGI had conducted, because at that time, as the differential diagnosis of epilepsy, we did not knew that cysticercus was the one who what was causing seizures. So what was happening was there were lots of biopsies conducted on patients who were having seizures and who were having these lesions in the brain, who were contrast enhancing lesions and many times calcified lesions. It was out of that research papers that were published to by these were the biopsies which were done by the neurosurgeons, published way back in 1980s in PGI Chandigarh and all over the world, that we came to know that this such a huge disease burden was actually caused by such a small tapeworm. This was such a small egg of the tapeworm which was migrating to the brain and causing seizures. And now we know that neurocysticercosis is such an important cause of seizures. Now, at that time, we used to admit the patients, we used to give them praziquantel, we used to give them steroids so that the seizures may not increase, patient may not go into a grand convulsive state because of the edema which is causing. But no longer that, we have matured in our treatment of diagnosis and treatment of neurocysticercosis to such a big extent that now this is no longer a big disease. We can easily, patient who's come with seizures, we do their CT scans, we do their MRIs, we find that this is a neurocysticercosis, we give them treatment, and it's so easy that with our patients we are not we are very comfortable treating our patients because we know that we will be able to treat it. This is not a big disease who it doesn't need no biopsies these days. We don't ask our patients to go to the neurosurgeons and get your brain biopsy done. No, we just treat them simply. uh, Only our CT scan findings or an MRI findings are enough to give us the diagnosis of neurocysticercosis. Well, leishmaniasis, most favoritely called as Kala-Azar, it was, it is can be caused by the bites of the infected female sandflies, and in severe cases, it affects all the internal organs, the viscera. Patient gets a face ulcers, discoloration of the skin, discoloration of face, scars, painless skin ulcers. Patient gets Patient is a dark complexion patient who has dark skin and fever with hepatosplenomegaly and affects the mucosal tissue. It Isolated cases probably are still seen in Bihar, UP, Jharkhand, and West Bengal. I haven't seen a case of Kala Azar for so very long. I think it's been only during my PG days, or subsequently 5 years later in my practice, I had seen one or two cases. We no longer see them, but isolated cases can still be seen in fewer of these states or migratory people coming from these states. So it's very, very important to ask the history of the patient, travel history of the patient, and how long the patient's been residing in these areas. The work that health agencies India have done to decrease or reduce the Kala Azar burden, this is a huge learning models not only in India but for other countries to apply to public health programs to eliminate these infectious disease, because even the medication was available only through the government sectors in these very states only. The cases of the migrant laborer which I diagnosed here in Punjab, I couldn't find the medication. I had to, send the patient to their basics, to their parent state to get the treatment for leishmaniasis. As I was already talking of leprosy, that I talked about the center which is in Doraha, the leper center, which is our favorite center. We act like an NGO to help them in their camps, in their needs of clothes, of our old clothes or anything which a lot of food material we go and serve them, because this marginalized sector of leper patients still are there in our society. Most of them are treated because we had a very strong national leprosy eradication program. Now the drugs are Depson and all, they are very nicely available. This is called by Mycobacterium leprae, and this mainly affects the skin, the peripheral nerves, the mucosa of the upper respiratory tract and eyes. There are mainly two types of the disease: the possibility, if there are five mucocutaneous, numb, or hypopigmented lesions, or if there are more than five mucocutaneous lesions which are hypopigmented and which are numb, it is called a multibacillary leprosy disease. And the diagnosis can easily be confirmed by the skin biopsy, and we have to see the acid fast bacilli, the leprous Mycobacterium leprae in them, and then the diagnosis is made, and a complete elimination is possible. But whatever disfigurement occurred before you treat them, or the limb losses occur before you treat them, that are irreparable. But no longer people are losing limbs or people are losing anything by this disease. Well, now this is most important. The disease is spread by mosquito, because every year we are afraid of, every year the rain monsoon is here. We are always, our systems, our government sector is again becomes very active in prevention of mosquito related diseases, because malaria, dengue fever, chikungunya, yellow fever we don't see here, but West Nile fever and Eastern equine encephalitis, these three are, we don't see them here. But our problem of India, of Punjab, of northern states is the malaria, the dengue fever, and the chikungunya. And this exists, and this is our challenge of this tropical area in this rainy season. So, dengue fever is caused by the bite of a fresh water mosquito, which is called Aedes aegypti, which has been infected with a dengue virus. The mosquito spreads the disease from one patient to another patient. So, that's why once it starts spreading the disease from one to other, it really becomes an epidemic. It may be a very mild disease if it is only fever, myalgia, rash, bleeding tendencies, or retroorbital pains, or if thrombocytopenia is not very bad. So it can be like a very mild disease. You don't need to give anything except, treat the fever. It's a viral disease. Within a week, you just need to monitor the patient. You can keep decreasing, taking care of the fever as a supportive care, as a symptomatic care, and the patient will get well better. But when it is bad, the thrombocytopenia is very, very bad, then patient can ultimately and even very quickly go to dengue, hemorrhagic fever, bleeding tendencies, bleeding per rectum, and you lose the patient very quickly. So the basic symptoms are headache, fever, bleeding gums, nose, rash, bruising. That's what in our admitted patients we see any purpura, any fresh petechiae, any rash or bruise. And even in bad cases, when there were a dengue kind of an epidemic, we had huge hemorrhage into the muscles. We had treated a patient of a splenic rupture who survived because of the splenectomy needed to be done on that patient, and you understand splenectomy is no joke doing it in a dengue patient. And even acute pancreatitis and collection of hemocytis and encephalitis and dengue shock because of the myocarditis. Similarly, leukopenia, all the lines are low, thrombocytopenia, neutropenia, and eosino- eosinophilia, which comes late, the coagulation factors doing because of the hepatic involvement, your INRs jumping high and to 2 and 3, and you are not only transfusing platelets to the patient, you are transfusing FFPs to the patients going to shock, hypovolemic shock, and dengue hemorrhagic fever, and also vomitings, intestinal bleedings, hepatic injuries, bladder thickenings, so on and so forth, joint pains, basically what we call multi-organ involvement, multi-organ syndrome, MODS, which comes with a bad dengue. Whenever there is epidemic, we have seen lots and lots of mortality with dengue. It may be from mild to moderate to a very very severe bad disease, and you lose patients in your hands so quickly. Well, chikungunya, don't forget if the patient comes to you with arthritis. It might be an infection which he had suffered even 3 to 6 months back. Because arthritis, arthralgias, they keep on persisting. So, if a patient you comes to you with joint pains, of course you are going to investigate the patients for rheumatoid, for Ellis, for uric acid and every other cause, autoimmune cause of arthritis. But also don't forget to ask the history. Ask any history of fever which had happened to him within even 3 to 6 months. Patients can continue to have mild grade or bad arthritis or arthralgias even for 6 months. It is a neglected viral disease. Again, it is transmitted through the Aedes aegypti, and this carries the same mosquito carries dengue and yellow fever, and this has been identified in more than 110 countries. It is typically there is no mortality with this, very low mortality, but the disease can cause a very prolonged morbidity. I've seen patients who are really suffering with lots of inflammations from the myositis, from the arthritis, but it really causes any neurological disorders or morbidity. There is no specific treatment, no vaccine available, making the prevention and symptomatic treatment as the primary management strategies. Malaria is our huge, huge concern. As we know that Plasmodium falciparum is a life-threatening disease, and it is spread to humans by the female Anopheline mosquito. And there are mainly we know the five Plasmodium parasite species which cause malaria in humans. The falciparum and vivax, they pose the greatest of the risk, and they are the deadliest. The falciparum is the deadliest because it is the falciparum. And in 1984 and 85 in Punjab, there was, I would say, an epidemic of Plasmodium falciparum, where we had seen cases of Plasmodium falciparum causing high grade fevers, myoglobinuria, acute renal failures because of acute tubular necrosis, patients causing meningitis, encephalitis, unconsciousness, liver failure, ARDS, chest involvement, and multi-organ failure, and patients who were acute tubular necrosis. I remember these patients were unfit for hemodialysis because They were so deeply jaundiced and they were in shock that many times, many times, we were doing peritoneal dialysis in these patients, and there was lots and lots of mortality in that time. And for diagnosis, we were relying on the slides, or whenever the patient was having a high grade fever, quickly we were running to the patient to pick the patient and get a slide for MP. Many times we were not able to diagnose. Two, three patients we had diagnosed getting malarium parasite falciparum from the bone marrow. So we were looking for getting parasites to make our diagnosis from every possible way. The symptoms could be very mild, but it could be life threatening. From mild fever and chills, like I said, the life threatening multi organ failures, unconsciousness, and seizures with falciparum malaria. This is a huge concern. Lately, only I had a patient who had come to me, who was admitted with pneumonia, with LRTI. He's been having fever for last 3 weeks, and he was given all kinds of antibiotics, but he was not responding. His fever was not responding. His MP from outside came negative, and again in one of the spikes of fever, we did his MP, and it came out to be positive, and it was so easy to treat him with simple Nevaquine injections or Lariago. We got treated him, and even if we are not able to treat with Lariago or chloroquine, we have the availability of what we call as Falcigo or artesunate injections, which we treat falciparum malaria with. So these days, for last couple of years, we have not seen a very bad or a life-threatening case of malaria, though it is a possibility. And because in past we have seen huge and huge numbers of mortality with falciparum malaria. Well, rabies, I was just talking about rabies. This is a viral disease transmitted to humans through the bites of infected dogs, cats, bats, jackals, monkeys, and mongoose. It's a viral zoonosis caused by Lissa virus. And the good thing about it is that it's a vaccine preventable disease, and infected material is the saliva of the rabid animals. So whenever the patient says, there's such a very small bite, or it's a very small dot, so still we must give anti-rabies vaccination to the patient, because there is no harm. Because if we don't treat it, it is life threatening, and encephalomyelitis caused by rabies basically can never be treated. And the thousands of cases are reported annually in the endemic areas in Africa, Asia, and actual numbers is very underestimated because of the huge public awareness now. Whosoever gets a dog bite, which is every now and then, considering the number of dogs we have on the streets which are not vaccinated, so there's a huge number, actual numbers which are totally underestimated. But thanks to the good public awareness, that people know that a dog bite needs a anti-rabies vaccination. And the good thing is there's a good window period for the rabies vaccination to become effective before the patient gets encephalomyelitis. So the symptoms we don't need to go, because again, personally I have seen lots of patients of rabies, but not for at least last 10 years. We've not seen the patients, but we've been giving anti-rabies vaccination very frequently, very often. Well, snake bite is again, now the rainy season is in. I My hospital is situated outside the Ludhiana, and we cater to the need of the rural population. And right now, I have a child who is continuously to be admitted. He is on ventilator. He is a 8-year migrant laborer who's admitted with the neuromuscular snake bite. In our area, crate is the most common. Cobra is also common. Cobra acts on the postsynaptic neuromuscular junction, and crate acts on the presynaptic neuromuscular junction. Russell viper and saw-scaled vipers, they cause hematological features. in these areas, in our area of Punjab, Rajasthan, Haryana, and Himachal, we don't see much of vipers, but we do see lots and lots of crates and cobras, and they cause neuromuscular paralysis. And this is such a huge challenge for us to treat crate. And this child, it's his sixth day on ventilator, and today we have weaned him off the ventilator. Today he's better, and this has been a huge challenge to treat this patient, because every now and then the endotracheal tubes would get blocked, and the patient again would we need to change them so very often. So you really have to be on the guard to treat these patients, because if the neuromuscular blockade is very, very bad. I will tell you a very, very important case, which was a case I treated for a neuromuscular snake bite paralysis. This was a migrant laborer who was brought to me, I think around 10 years back, when I didn't had a huge ICU, and when I only had a one portable ventilator. So as soon as the patient we saw there was he's gone into a complete paralysis, we intubated the patient and we were maintaining him on ventilator. Third day passed, fourth day passed, there was not a single muscular movement of this patient. And since he was a laborer, the whole of the around 20-25 of his friends and family came to me and, blaming me. He is dead. Why are you putting him on ventilator? Give him to us. We don't have a single money. We don't have money to even drink tea. And you are, they were blaming me for why are you keeping our patient? I was like, how can I switch off the ventilator? How do I do his brain to see whether he's brain dead or not? I was kindly, in my minds of mind, sure that he was not brain dead, because I had intubated him in good time. And this patient had, uh, during that mission, he never had a cardiac arrest. And my mind says, if there was never a cardiac arrest, even hypoxias would probably not make him brain dead. And I was alone standing, taking such a big challenge. I was looking into if I could, give the patient to them and switch off the ventilator. Was it ethical practice? I was looking at the court decisions. It was unethical. I said, no, I will not switch off the ventilators. All of them went away, leaving me and my team alone with the ventilator and the patient on them. We continued to treat him. 2 days later, we were able to patient had started responding. He became better, and we were extubating the patient. When we were extubating the patient was kind of falling from the bed. I was saying, "Hold him, hold him." And as soon as I extubated the patient, he says, "नहीं, मैं गिर नहीं रहा हूँ, मैं आपके पाँव छू रहा हूँ." जब ये सब कहते थे, इसको ले जाके हम जला देंगे, मुझे सब सुनता था. It was goosebumps on me and on a whole of our team which was standing there. That was when we realized that there, which were the cranial nerves which don't get involved in the snake bite, because every cranial nerve, say seventh nerve, say third, fourth, sixth, no eye movements, complete ptosis, complete facial nerve paralysis, complete glossopharyngeal paralysis, complete ninth nerve paralysis, 10th nerve, 11th nerve, 12th nerve. What doesn't go is the auditory nerve. So, dear friends, be careful when you have such a patient who looks to you as a completely unconscious patient. He is not unconscious. His neurologically, he is completely alert. He is listening to whatever you are saying by his side. Please don't pass any of the remarks or any of a loose talk when you pass by this such kind of a patient, because he is listening to you. His eighth nerve is intact. And when they come when even for the first sign, when they start showing signs, and you tell them, okay, you believe and you ask them, they will follow your signs. You tell them if you can move your right hand, left hand, they will follow your hands. And this is was this is what I learned with one of my first patients, uh, that yes, this is the cranial nerve, the eighth nerve, which is doesn't get involved with the snake bite, and everything else it gets involved. Olfactory, we really don't care much because it's okay. Optic nerve also, because patient has ptosis, third, fourth, sixth nerve paralysis, his eyes are closed. So, but as soon as he can open his eyes, he can see everything, he can smell everything, and the auditory nerves is always there. So always when you have a patient, there should be no loose talk around this patient. Never say he may not get survived. Always give them hope to these patients, because we have to give 100% cure to these patients. All of these patients must come out of this. So whenever there is a snake bite, what should we do and what we should not do? These patients, don't waste time taking them to the snake charmers. Don't try to suck the wounds. Don't try to cut the wound. Don't tie the ligature around the wound. I have one of the patients, say around 10, 12 years back. He had tied such a big ligature, such a strong ligature, and it took 3, 4 hours that he had completely suffered. It, the limb needed to be amputated because of the gangrene. So that was a big eye opener, because don't give it such a ligature around the wound that you completely block the artery. So don't burn the wound, don't apply any herbal paste. What you do is treat the patient like you treat a fracture patient. Immobilize the affected limb by any wooden or any scale, and just put bandages around it. And rush the patient to the nearer hospital which has a ventilatory facilities and which have a stock of anti-snake venom. That's all you need to do it. And the signs and symptoms, now let me come to you. This could be just a clinical examination. Only patients who would come to with the neuromuscular paralysis, the first patient, actually you ask the history. There could be no bite mark on the skin. These patients will come to you early morning. The bite is around 1:30 to 4:30 a.m., because that's the time when the snake actually is coming out of the burrows which has been closed by the rainwater. And this is the time when the snake actually is looking for a mate, and it can bite anybody. If there are 5 people lying on the floor, it could bite anybody. The side, for sparing 4 people on the side, a center one. A child may not give you any history of what is happening to him. It may be a painless bite. But what? And suddenly they would say, I got a pain abdomen. This pain abdomen, many times a patient could just come to you with a pain abdomen. It's actually what you will see. It's a hypersensitivity. The child doesn't let you touch the abdomen, child or an adult. They will say, I've got a severe pain in the abdomen, and he will not let you touch the abdomen. It's that kind of a hypersensitive skin of the abdomen, followed by the patient may say, something is happening to my throat, and then subsequently they would say, behoshi ho raha tha isko. So these could be the only symptoms if you go deep into the history. Otherwise, you have to immobilize the extremity and start the treatment, monitor the patient, give a airway, and invariably we need to intubate these patients. So you should be ready with everything, because once the patient starts paralysis, it will not, its respiratory arrest will not give you much time. You will have to be very quick in your intubation and putting the patient on ventilator. So the everything has to be by your side, and you have to be very observant, and you have to monitor the patient very, very closely. So this is the prevention which we need to do. Don't walk on the long grasses, wear your shoes, beware. And this actually happens to the migrant laborers who are staying in the fields of Punjab, Haryana, and Himachal, and they are. Uh, but not only that, we've had snake bites, which the persons, they were in their bedrooms, and the snake has climbed on the bed, and it is the patient was on the bed, and he's come to you from there, from a good socioeconomic status. uh, well, that was. I think it's very, very important. Snake bite, nobody should miss, and the idea should be that 100% cure rate should be there. The only thing is we have to be very quick in our treatment. So, out of the fungi, mycetoma, it's an infection again, which is there are many other fungus also, but only immunocompromised people will get these diseases. So, what interventions? Prevention is very important. Vaccination, I said, and then deworming is very, very important by just giving simple medication to most of our patients, even without getting waiting for this tool routine report that they have this strongyloides or they have the hookworm or they have ascariasis. We can treat the patients. It costs you nothing actually, because collecting a stool sample, examining a stool sample, these days, hardly I think any one of our new pathologists probably haven't seen helminths as well. So safe water, sanitation, hygiene, very, very important. The changing landscapes, the urbanization and migrations, they are spreading these neglected tropical diseases. Climate change, travel and trade, they are increasing the spread. And of course, we need to do all the specific tests. Dengue antigen tests, very easy to do it. IgM serology, the test comes out to be positive very soon. MP, malarial parasite, sometimes very difficult to get it. Leishmaniasis, also, RK39 strip test is possible. Then schistosomiasis, strongylitis, the tests are possible, but for helminths, you can treat them as such also. And prevention is by, at the individual level, you must see for safe water, sanitation, wearing shoes, prevention from mosquitoes, mosquito nets, repellents, and uh, even in our rainy seasons, even freshwater mosquitoes needs to be, we need to prevent them, and we need to do a repellent, we need repellents from them. For the community and public health, mass deworming campaigns, vector control, insecticides, community education, surveillance, and outbreak response. There are lots of challenges: poverty, lack of infrastructure, drug resistance, stigma, and underreporting. So, integrated disease control, combining these control with the maternal child health education, school based deworming, using of existing health workers for surveillance, intersectorial coordination between health, water, and education. Again, I said migrant with the rash, we talked about leprosy, don't miss it. And infections, I told you about it. And we do see cases, lots of children, and as in schools also, we must deworm. And the final takeaway is, don't neglect the neglected diseases. Simple tools. Keep your mind open. Differential diagnosis. This can lead to early detection. Be empathetic. Education. Public health is the key. Stay alert to the global trends in the tropical diseases. Well, 2030 is really a signal to the end of suffering from the neglected tropical diseases, because WHO is very optimistic, although significant challenges remains. Consequences arising from climatic change, conflict emerging, zoonotic and environmental health threats remains challenges. Socioeconomic inequalities remain a challenge, and impact and access to healthcare services remain a challenge. Adequate housing and safe water and sanitation remains a challenge. But WHO roadmap offers all the tools required to overcome these future challenges, to build delivering health services in an integrated cross-sectoral manner. Very hopefully, we will be able to end the tropical diseases by 2030. Thank you very much. Hello?
Thank you so much, ma'am. Hello, ma'am. Am I audible?
Yes, yes, you are.
Yeah. Thank you for this wonderful presentation, ma'am. We do have some question if you like to take that up.
Oh, sure, sure.
So, ma'am, the
Bombard.
first, yes, ma'am, you're saying something?
I said bombard all the questions.
Sure. So, ma'am, the first question is, what are the practical challenges in initiating timely and effective treatment for NTIS in primary care setting?
Well, I think I already talked about it. We talked about malarial parasite, we talked about dengue, we talked about chikungunya. These, there are lots of challenges in diagnosing only because many times you don't get it, but many times we have to treat it even just with our clinical acumen that the fever is not responding. Why not treat it? Add another antimalarial medication even if you are not getting it. And to treat thrombocytopenias, we must look for dengue. These are not difficult to diagnose. You only need to keep your mind open. And as I said about snake poisonings, uh, because many times snake poisons can be missed because it's a there are huge, the deaths happens only when we are missing it. This is a huge challenge because no investigation is going to tell you about a snake bite. So the patient may not come to you with any history. They may just come to you with a history that he's just become unconscious. That we saw him unconscious in the morning. He's not responding. So keep your mind open because you will be able to treat it if you have seen number of patients, if your mind is open, and if you think it is, you will be able to treat it. the,
Thank you,
uh,
ma'am.
the we don't have lots of tests. Look for snake bite. We don't need to. We don't even need a single test to prove that this is a snake bite.
Thank you, ma'am. Next up, we have, are there specific red flags that warrants referral to higher center in case of suspected NTIS?
Yes, yes, it is. The huge flags again are because, as I told you, even with malaria, with falciparum, there are huge deaths. Even with dengue, we had mortality. So flags are your investigations in these cases. If you see multi-organ involvement, if you see very severe thrombocytopenia and you are already treating it, patient is again complaining of pain, you have seen a spleen or a huge collection of blood under the spleen. In a case of dengue, he is complaining of severe pain radiating to a leg or somewhere. That means he's bled somewhere. That means it's a red flag. A huge thrombocytopenia, in spite of treatment, is a red flag. Your decompensating liver enzymes, decompensating kidneys are a red flags. Maybe even in a case of malaria or a case of dengue, and for snake bite, especially if you don't have the ventilatory facilities, don't keep a patient of snake neuromuscular snake bite with you. You must immediately refer the patient where the patient can get the anti-snake venom and the ventilatory care. This is an emergency situations. Patients with encephalitis, patient with multi-organ involvements, because all these, even helminthiasis, even dengue viruses, all these they can cause multi-organ involvement, and the red flags will be shown to you by the investigations like ABGs for lungs, by LFTs and RFTs and INRs and BTCTs, all the investigations and your ultrasounds and X-rays.
Ma'am, there is one last question. Should NTIs be part of routine differential diagnosis in fever of unknown origin?
Absolutely, yes. Absolutely, that's what I'm saying. That many times you may not even get a diagnosis, And that's how I just gave you an example of a patient who was being treated from pneumonia for 3 weeks and for an respiratory tract infections, all kinds of antibiotics. And just now that we found that he is MP positive, and his fever, once we had treated him for malaria, his fever vanished, which was there for 3 weeks. It is all the NTIs, they have to be for the cause of POU.
Thank you so much, ma'am, for answering all our questions. That's all from our audience, ma'am. Before
Right.
concluding, any take-home message?
I did give you the take home messages from this, that we should never forget these fewer diseases, at least in our area, which we see is uh, malaria, dengue, chikungunya, and snakebite. So these are the very, very common neglected infections, and don't hesitate to deworm a patient. Keep on looking even for leprosy patients. You may once in a while, in any kind of a migrant population, you may be able to get it. So they have to be in the differential diagnosis. The lots of them we had been able to eradicate, which the list I gave you during my talk, and but lots of them are still our huge challenges.
Thank you so much, ma'am, for joining us today. It's a pleasure to have you here, ma'am. It's been a
Right.
wonderful session. Thank you, ma'am.
Thank you, Skyan.